Okay, my name is Jonah Manning. I am a nursing student at Wenatchee Valley College, and I'm going to do a presentation on anaphylaxis for Pathomat for our clinical lab time. We did a simulated lab where we had a pediatric patient suffering from a severe or systemic allergic reaction. And so I'm going to spend some time talking about what anaphylaxis is, how to discriminate against maybe a milder allergic reaction. And really, I'd like to spend more time on some of the more interesting / arcane aspects of what I've been able to learn while studying this condition. And so allow me to move quickly through some of these fundamentals so that I don't take so much time that I bore my audience and you just set it on 2 times speed and race through it. So I'm going to get into it, and hopefully I can be clear in this presentation. So what we want to learn is how to recognize anaphylaxis. And we're going to look at some of the principles that I've written here on this board. And if this board is difficult to read, then please stop the video and you can pull up the photo that I sent along with this video so that you can look at that as a guide to the content of the lecture. That'll be pretty helpful. Otherwise, you can review this material in sources that I have available if you're so interested. But most of this is coming from both Medscape.com and UpToDate.com. Anaphylaxis is it's a reaction that we're having to a specific allergen. We've been talking about immune response and how factors in our circulatory system can recognize invaders, and predominantly we're looking at antigens. Well, allergens are a specific type of pathogen, and I might actually redact that. I might say it's a specific type of antigen, and they're interesting because they're not pathogenic per se. They're things that are regularly found in our environment, like nuts or latex or iodine or medications, things that aren't inherently dangerous, and our bodies become sensitized to them. So let's just review quickly what an allergic reaction is. We have maybe a bee sting, for instance. When that venom enters the bloodstream, it's going to, in the case of an allergy, it's going to educate the immune system to it. It's going to get identified. And at that point, nothing is going to happen, but we just have educated our adaptive immune system to something that we consider to be an invader, and we want to raise a more specific and stronger response the next time. So we might have some signs of inflammation, some heat, some redness, some swelling, some pain, to name a few. But the next time that we get stung by a bee, we're going to have those local reactions, but in this case, our adaptive immune system is going to be more prepared and hyper-prepared, in that we're going to see a global or systemic response of both basophils and mast cells releasing things like histamine specifically, but also other types of cytokines and prostaglandins as well. And when this happens on a systemic level, we get specific and life-threatening signs and symptoms. Specifically things like hypotension, because of the widespread vasodilation that takes place secondary to things like histamines. And so vasodilation can create distributive shock. Distributive shock in the presence of anaphylaxis or an antigen is going to be called anaphylactic shock, and it's one of the life-threatening presentations of anaphylaxis. But we also are going to see things like respiratory distress, which is when we get bronchoconstriction and we get a presentation much like asthma or COPD or other presentations that we learned about so far, where we have shortness of breath, dyspnea, air hunger, things, and generally difficult breathing. We can get, in the worst cases, stridor, which would be more due to upper airway edema, which is going to be a sign and symptom. We get angioedema, which is facial swelling, tongue swelling, lip swelling, things like this. We're also going to get wheezes in the lungs, which is where we're seeing that sort of bronchospasm and bronchoconstriction. And this is because of that massive histamine release that we get because of the exposure to an allergen. And so that's the gist of what's happening with anaphylaxis, and how we have many different things that can cause this unfortunate response of the body and the immune system, sort of creating a pathological state that can be fatal. And that's what we're going to kind of get to at the end of this, looking at the fatality, how it's changing over time, and how big of a risk is it, but more to the point, recognizing that when are these cases fatal, and how do we as providers recognize that our really prompt and quick action is going to hedge all those bets against fatal cases of anaphylaxis. Because anything in between we can manage, and most of all of these signs and symptoms that we'll talk about don't leave sequelae, and they're not going to have long-lasting damage. But if respiratory distress leads to respiratory arrest, then we haven't provided prompt care. Or if distributive shock isn't rectified with good shock treatment, then that can lead to cardiac arrest. And those are things that we need to learn to look for, to be scared of, and to prevent by good provider care. So moving on through the pathophys, who actually gets these type of reactions? Well, that isn't very clear. I might talk about a couple cases where we have worse outcomes. For instance, asthmatics have a higher likelihood of dying of anaphylaxis. Why is that? Well, it's really because an anaphylactic shock situation might be misconstrued as being an asthma attack, because they may look similar with respiratory distress. But albuterol is not going to resolve an anaphylactic shock. It might work on the beta-2s, but if we're looking at distributive shock, it's not going to do anything to help get some vasoconstriction to keep our blood pressure in a safe space. So when someone has what they think of as an asthma attack, and they have a history of allergies and anaphylaxis, we need to be very cautious that they haven't come in contact with an allergen, because we may mistreat them. So that's a potent risk factor. Also, people who are taking beta blockers and ACE inhibitors, beta blockers particularly, because the great treatment for anaphylaxis is epinephrine, and they're going to be resistant to epinephrine because they're blocking the beta receptors. So they might get some effects from the beta 1s and from the alpha 1s, which are the receptors that the epinephrine is working on. But that beta 2 is really what's going to allow the bronchoconstriction to relax and for us to be able to get more oxygen on board. And so those are two cases where we're going to be really concerned, or patients who have a higher risk. Interestingly, we've been looking at how cesarean sections, if you were born by a cesarean section, we might have higher risk to develop allergies. Also, early childhood antibiotic use. I have not studied either of these yet in our module, so hopefully I can have some more information on this in the next few weeks. But we're looking at who gets allergic reactions, and there is evidence that allergic reactions are on the rise, predominantly with regard to medication allergies. Okay, so moving on once more, I'm going to talk about some of the things that we become allergic to. Peanut allergies are very famous. Bee allergies are very, very famous. So let's be aware that those are real, and they both can be life-threatening. But peanuts are part of a larger group that can cause allergic reactions, and that's just nuts in general. And we have medications, which as nurses, we want to be hyper vigilant about, because they also make up one of the potentially most dangerous forms of allergic reaction, which is the fact that when we have a medication-based anaphylaxis, we have a higher likelihood than others to go into distributive slash anaphylactic shock, and patients can die within 5 minutes. So it has the fastest rate of onset and quickest mortality of all the groups are those medication administration cases of anaphylaxis, where what you'll see here is by food allergies, we have a higher rates of respiratory complications, and so that might actually alter our care, in that these might be patients that need to be seated in a Fowler's position to maintain that airway. Where, as a rule, we want to use anaphylactic shock management, which is generally we're going to have patients supine and even raise the legs a little bit, although that aspect of it is not as evidence-based as the benefits of being supine, and maybe obvious, maybe not, but in a pregnant female patient, we want to have in a recumbent, laterally recumbent position, so they're not going to have supine hypotension. And so recognizing that there are some management modalities that sort of we might take into account depending on what the actual allergen is. And so quickly we have food, shellfish, meat, really, it's true. It's called alpha-gal. It's a protein in meat. Very rare, but it's become a little bit more common, and it's actually, I have to dig deep for this, I believe it's tied to having been bitten by a specific type of tick. Very interesting, but so it's regional to where this particular tick species is, but it generates an allergic reaction to a protein found in meat. Milk and eggs, these can be problematic because we find milk and eggs in different types of vaccines and many different types of products that have been sort of prepackaged. Very common foods, and so the management of your diet, if you have an allergy to certain foods, can really change your lifestyle. Environmental factors often lead to allergies and rarely lead to anaphylaxis. Pollen, dander, sunlight even. I jumped over iodine and latex, also things that we as nurses really need to be super mindful of. Using those tools, latex is moved out of medicine a lot because of these type of allergies. But anyway, back to environmental allergies. Less of a concern for us for anaphylaxis, but large sunburns can present with dangerous problems. Our toxins are really interesting because we talk a lot about bee allergies. Well, bees are just one specific type of insect in a larger family of Hymenoptera. So any of those stinging insects, such as wasps and hornets, and other insects like ants, can create, through their envenomation, an acute allergic reaction. And so recognize it's not just a matter of only getting bit by a bee. It can be other insects as well. And it's interesting to note, I know a lot of us when we were kids, some of us were really interested in snakes. And, I grew up and I had pet snakes, and you'd always wonder what the most venomous snake was in the world. And they talked about things like black mambas killing patients or killing individuals in less than 5 minutes. And what I've learned by being in the medical field is that it's not likely that the venoms themselves are causing those really rapid time frames for mortality. It's actually an anaphylactic response. So it's not necessarily one snake or another, or one venom or another, but whether it's triggering an allergic reaction. And patients are going into anaphylactic shock and often dying of those essentially cardiopulmonary symptoms. So extreme hypotension causing hypoperfusion and then causing cardiac arrest. So different presentation again, but recognizing that that's what's happening pathophysiologically with some of our poisonous animals. And as a side note, a medication that has the ability of causing anaphylaxis is the antivenin for some of these snake envenomations. So we don't like to use antivenin unless it's really indicated. and there's going to be a different sort of progression there, but they can cause patients, and sometimes we're actually pre-medicating snakebite victims with epinephrine just to assure that we're not going to get an anaphylactic reaction. Prophylactic epinephrine, pretty interesting. So there are some cases of exercise-induced anaphylaxis. Actually quite rare, like 1 in 2,000 people have them, but I knew of one anecdotal case locally who actually received 7 injections of Epi before they reached the hospital, and that's extremely rare. 1 to 2 administrations of epinephrine is sufficient, and I don't actually have a number for it, but in a vast majority of cases, 2 doses of Epi is going to be sufficient. 2 doses available is really going to be really important in our care, but that many is extraordinary. So these are our nursing fundamentals, and back to our fundamentals, and I know we have expectations for our patho maps. I've attached a second document that looks a little bit more specifically at maybe some of the other things that our professors like to see in our patho maps. But from there, I want to move into, which is part of our patho map, but nursing care specifically, and a bit of an after action on how we performed in our virtual simulation, and really how I want to learn from it and be a better provider moving forward. So we're going to look through a chronological progression of nursing care, provider care, and to some degree bystander care, how we respond to anaphylaxis. Because it's worth noting that anaphylaxis isn't something that we're going to see written up in a patient's chart that they're experiencing this thing, and then we read up on it and we go and we provide care. This is a syndrome that happens very, very acutely and happens really rapidly, and we're really going to be leaning on protocols and standing orders rather than getting a lot of direction from physicians early on, because it can progress and kill in less than 5 minutes. If there's one take home maybe from this whole lesson, is that mortality from anaphylaxis can happen in 5 minutes. So we really need to be forward in our care, aggressive in our care, and in this regard, we learned something from EMS, where it's not that we're doing these nice long assessments. We need to start thinking about Maslow and the fact that our care really starts with our ABCs. In EMS, we have one thing that comes before ABCs, and that's essentially something we call a scene size up, which has to do with our safety, but it's a bigger, more global look at safety. And from that regard, we also look for resources. And so I'm going to I'll make a bridge for the first thing we want to do, which is stop harm being done. So if we come upon a patient and we're suspicious, index of suspicion for anaphylaxis, or maybe we just see their chief complaint and they got stung by a bee, the first thing you need to do is remove the allergen. It only really matters if we do it rapidly. 90% of the venom from a bee sting is going to be injected in the first 20 seconds, something like 60% of it in the first 7 to 10 seconds. Time matters, and there used to be a lot of education about getting out a credit card and use a credit card to try to get these bee stingers out. Forget all of it. None of that matters. It's too slow. You just have to just use your fingernail, pinch, pull, whatever it is to get it out. And honestly, from a nursing point of view, you're not even going to be present when it matters. So perhaps we're going to remove it to prevent infection and other things. But from a medical point of view, when we're talking about removing allergens for bees, you have to be very, very prompt. When it comes to food, it's like, are there still particles of peanuts in the patient's mouth? Can those be removed via suction or something like this? If there's a medication being infused, has it been stopped? You can't do all of the rest of this expecting to get a positive result if you're still pushing a medication that's causing the syndrome in the first place. You don't need an order to stop a medication infusion if you think it's causing an allergic reaction. So be super mindful of looking for our simple signs and symptoms. And this is why we sit at the bedside for at least 5 minutes when we're starting a new infusion of a medication. And that's because these symptoms, which aren't even on the board, come on really, really rapidly. I believe I stated the symptoms, but I did indeed. Right, we're talking about respiratory distress, hypotension, widespread hives, and potentially edema, angioedema. I'm restating them because something that's important is we're going to want to look at these symptoms and draw a really firm, essentially a diagnosis. We need to have an index of suspicion that this is what's happening so that we can actually stop that infusion. And though there's not a single firm definition of what anaphylaxis is, what you'll see in the literature is that it's going to be I'm trying to think of the best way to say this, but a collection of 2 out of 4 symptoms. So it's not enough to simply have some respiratory distress. You need to have respiratory distress and widespread hives. You can have respiratory distress and hypotension. Any collection of these 3, or hypotension in the presence of the allergen itself. Hypotension in an allergen equals anaphylaxis because it can be so fatal so quickly. Otherwise, we're looking to see respiratory distress with some of these other things. And obviously, clinical judgment comes in there. If you're having massive respiratory issues and you have an allergen but you don't have hives, okay, that can happen in pediatrics. And so you use clinical judgment. But recognizing that those are the 3 critical pieces. And I even forget, I feel like I'm forgetting one, but I think maybe the 4th was just the BP in and of itself being raised with anaphylaxis. But think about looking for systemic, essentially cadres of, vasodilation, respiratory distress, and widespread hives. If you have 2 of those 3, you've got anaphylaxis, indicate with having an allergen present. So what do you do when you think you have it? Remove allergens if possible. This is a life-threatening emergency. This is something that I think we didn't get good representation on our sim. This is an all-hands-on-deck type of situation. We're not necessarily going to have orders from a doctor saying, oh, here's an anaphylactic patient and give 2 liters of oxygen. Really, an anaphylactic patient is going to walk in the door and we're immediately going to converge on that patient and start getting essentially IV set up, cardiac monitors on, assessment done, O2 flowing. All this is going to happen with as much manpower as we can. Why? Because we have 5 minutes before a patient can become a statistic secondary to this condition. So let's get all hands on deck. If we're not in the hospital, we're calling 911. If we're in the hospital, we're going to follow whatever our protocol is. If we don't have one, we need to work hard to get a protocol in place. But really, we need a resuscitation team, or at least be in the ER where we have a really firm protocol for how we respond to these. What is that going to be? It's going to be our ABCs. This is what I was trying to get to with Maslow. We have to make sure that we're thinking in a resuscitation point of view. We're managing our critical systems. How is the airway looking? This patient can have a very bad airway. We can get, we'll hear stridor if that's the case, when we get sort of a bronchoconstriction, but really I'm talking about swelling of the lips and tongue and facial features. Often our paramedics are going to get intubation going really rapidly in this case. This is a case where early epi really matters. Cryotomies are sometimes done to save these patients' respiratory status if the airway is becoming occluded. For us, it means that if the patient is dizzy and maybe obtunded, that we're going to be managing that airway not aggressively, but passively, but patient position, keeping a head tilt, chin lift, making sure that they're breathing easily and they're not getting sort of the tongue in the back of the throat. OPAs, NPAs, things like this may be indicated. Breathing, we're going to assess it. How's their respiratory rate? We're going to be paying a lot of attention to that respiratory rate going up and down because it's one of the hallmark indicators of this progression. Let's get those lung sounds. We might hear wheezes in the bases. Worst case scenario, we hear absent sounds. Circulation. This is really critical because we're looking for hypotension and we're concerned about it. We might see elevated heart rate because of the anxiety, which this is a very anxiety-inducing situation. But otherwise nothing. That's what we're going to be seeing. We can see pallor or central cyanosis if respiratory distress is coming on. But also, one of the hallmark symptoms of this is not only hives, but some erythema. So we might get some redness and swelling as our patient starts really shifting fluids to the interstitial spaces. So those are all things to keep in mind. Get these things done really quickly, or make sure that we have assistance in getting them done, because we're going to start trending these things every 5 minutes. At sea, when we're at circulation, this is the time to get that pulse oximeter on. Let's immediately start seeing where we're at with that pulse oximetry, because as we manage our airway and breathing, we're going to want to start off at 15 liters non-rebreather mass, because that's our shock treatment modality, which we haven't talked about yet in our coursework, but still stands true. When we're worried about shock, you provide high flow O2, but we're going to titrate that to generally above 95% SpO2. That's our standard for health. We want to make sure we're keeping our patient above board. Generally, if we're doing that, then we're going to save most of these patients, but we just have to worry about hypotension at that point. And so we're going to look at IV access of getting a fluid bolus and maybe even some vasopressors. But our go-to treatment is epinephrine, which is a vasopressor. So we're going to sort of manage the hypotension and the cardiac side of the crisis otherwise. But the prime treatment for us is keeping the airway open and getting enough O2 on board that they're not going into respiratory arrest. Okay, I told you I'd be moving fast. I'm trying to get through this material so we can talk about some fun stuff. So let me see where I'm at here. We're at C, so we're still doing our assessments for the most part. Once we've assessed our patient, we've gotten a good idea of the fact they are in anaphylaxis. As soon as I can get an EpiPen, then I want to administer into the lateral thigh. That is the ideal position to put Epi. Now, this gets us into some of the fun stuff over here that I've been really enjoying studying, which is where we fail in anaphylaxis resuscitation. And this is often the place, and that played out a little bit in the VSIM. We want to avoid IV administration of Epi. We even, a little bit, now the evidence is weaker here, may want to avoid IM Epi to be drawn up. And the only reason I can state that is because two reasons. EpiPens are preloaded, they're ready to go, they're fast. This is a time-sensitive syndrome. Time matters. So speed matters. If I can get an EpiPen and I can inject it into the vastus lateralis, then I'm going to get, ideally, an effect much more rapidly than I would if I have to draw up IM Epi. Or, worse yet, go for IV Epi, which as soon as you start looking at the documentation and the sort of process, all the calculations that have to go into it in a very time-sensitive situation, we're seeing an incredible amount of medication errors being involved in IV Epi. So again, IV Epi only really for patients with very specific indications that I'm not going to go into here. To be avoided. IM Epi is great. It's the way to go. It's easy to draw up, and this is going to be one reason why most ERs are not going to have EpiPens, is IM Epi is very cheap, and EpiPens are extraordinarily expensive. So they're less used because you can pay $5 for a vial, or you can pay $500 for an EpiPen, which will expire. Hospitals can't make those kind of financial decisions for just really, really expensive meds when we can draw up IM Epi pretty effectively, pretty quickly, and get it on board. And when we're giving IM Epi, it's generally pretty straightforward with regard to dosage. We can give 0.3 milligrams Epi. The dosage range is 0.3 to 0.5, but 0.3 isn't wrong, and that's what's in an EpiPen. Pediatric, we're going 0.15. And again, there are calculations that can be done for going down to neonates and smaller. And I won't go into the weeds there because I found it challenging. We have two different forms of epinephrine. We have what used to be called 1 to 1,000 and 1 to 10,000. Again, leading to a lot of confusion where most nurses are most familiar with ACLS protocols. We're using the 1 to 10,000 for cardiac type of patients. In anaphylaxis, we're not. We're dealing with a hyperimmune response, and we're using generally IM Epi, which is formerly called the 1 in 1,000. Now we're changing it to 0.1 milligrams per kilogram. Hope I got that right. I've been practicing a little bit, and I got it in my notes. But it's hard to read while you're talking in public. But I'm confident. So then you can leave me some feedback in the show notes, right? But what we're going to do is get that Epi on board really quickly. Once we've got that, we can continue to get the rest of the stuff. That was down here. Look, I already kind of ran over one of the important parts, but I was speaking to the fact that we need to have an allergen present before we can really have a firm diagnosis of anaphylaxis. Jump into your history to sort of better understand your ABCs. I call it bringing up your sample into your primary assessment. I know it's a little bit of jargon, so we can move on from that. But this is the relevant history that's important. And now, once we've got that history, we know that there's an allergen, then we're going to get that Epi on board. Ideally, an EpiPen, or at least IM Epi in the lateral thigh. For most adults, 0.3 milligrams. Get it on board, and now we're going to start trending vitals and watching for changes. It is almost never, there's no firm contraindication. Pretty impressive. There are considerations. There's for cardiac patients or people who are super tachycardic or people who are on opiates or sympathomimetics, scratch opiates from that. But sympathomimetics, then you might consider it a weak contraindication. But again, this is a life-saving therapy that's essentially mandatory because we looked at our other medications that go along with epinephrine here. None of them have the evidence behind them to support a singular treatment. They're all sort of adjuncts and work theoretically, but without the evidence to support it. And I'm talking about the H1 and H2 blockers, our antihistamines, and even our steroids. They work theoretically, and they work for different purposes. Particularly the H1 and H2, they're just looking at symptom management, hives, and the edema, reversing some of the histamines. They're not getting at the major life-threatening symptoms that epinephrine does. By essentially agonizing your alpha-1 and your alpha and your beta-1 and your beta-2, you're really getting at that vasoconstriction. You're opening up the bronchodilation, and you're actually increasing some of that sort of inotropic and chronotropic effects of the heart. So you're really getting after, and what I just learned is you're also stopping the mast cells from releasing as many histamines, which is ironic because that's what antihistamines are supposed to do. So why we have profound evidence that epinephrine is effective, and I hope I get to spend some time going into it, but we have only theoretical conjecture that some of these other medications, like our H1, H2 blockers, are really effective. We give them, and because they make a lot of sense, but not because they resolve anaphylaxis, because they don't. And we see that in looking at the fatality numbers of who actually dies from anaphylaxis are the patients who don't get epinephrine. Or sometimes they get it very, very, very late in the process. But often it's patients who don't get epi. So it's something to consider. Plenty of evidence, even placebo run trials where they're actually, telling people they have epi when they don't. No, epi works, and it's well established. So moving on, once we get that epi on board, then the bulk of our work is done. But we have to be concerned about hypotension, and so we're going to get IV fluids on. Another piece of learning for me was that we're not just dealing with distributive shock. We can also be dealing with hypovolemic shock because there's not only are the pipes getting bigger and short, but we're also shifting so much fluid into our tissues that we actually are volume depleted. And so getting IV boluses is really going to help to push that blood pressure back up. If the epi isn't enough to kind of reverse that vasodilation, we might use things like vasopressin or dopamine, which I believe I have on the board, to try to increase vascular resistance and get the blood pressure up. So some provider discretion there at the bottom. But that with fluids, maybe vasopressors, but just so long as we understand that IM Epi is the gold standard, and that's what we're after here. We do that, now we can start trending our patient. We are not done. Somewhere between 15 and 35% of our patients are going to have rebound anaphylaxis. That is unfortunate because if we just had one EpiPen and we were not in the hospital setting, I had that one EpiPen, great, the symptoms subsided. Okay, now 15 minutes later, those symptoms rebound. I have no more EpiPen. This is why it's really important to use EpiPens appropriately and not stab yourself in the thumb with them when you're pushing the wrong button or have it backed up. And we can look at what good EpiPen administration looks like, and we've already done it in the classroom. So rebound anaphylaxis is a real risk. And it's one reason why we believe something like an antihistamine or even a steroid is going to help. And I can show us this chart over here. So in red, we have the really amazingly quick action of our epinephrine. It's going to work in 5 to 15 minutes. We can re-administer in 5 to 15 minutes. But it's over in less than 30 minutes. So imagine all those histamines built up in your bloodstream, vasodilating, and all of a sudden 30 minutes later, your medication wears off. So ideally, you get another dose. And that almost always is sufficient, but not always. I'm drawing out 3 doses to make the point. But if you look at the green line, that is the arc of our therapeutic levels of our antihistamines, specifically diphenhydramine. And it takes an hour before its onset and about 2 to 4 hours for its peak. So you can see how an hour is a long time to wait for even the potential of it waiting. So we have a gap between here and here where we're really vulnerable to the worst symptoms of our anaphylactic, what does I call it? Syndrome. Okay, so Epi matters. Prednisone, it's 24 hours before it even really, 12 hours before it really starts to kick in. So they're much slower to work and, again, unverified. EpiPens matter. And when I say that 15 to 30% or so actually have rebound anaphylaxis, now we have to be concerned that that citizens sort of in the community, if someone's only carrying one EpiPen, it's really insufficient. The numbers are way too large to sort of warrant one EpiPen being considered safe. At best, it might buy you time until paramedics arrive via EMS. Because I believe that it's with our toxins, medications and our toxins that we have some of the quickest fatality times. But we're still, medications can be fatal in 5 minutes. Some of our toxins, less than 15 minutes is a mean time. And for food allergies, it's often 30 minutes. So 30 minutes may be enough time to get to the hospital, but it's barely enough time for 1 or maybe 2 EpiPens to be effective. So it's super important that we understand the importance of epinephrine so we can be a really good educator, which is hopefully where I want to sort of end this lecture, because it's what we're doing as a nurse is providing this type of care, getting these interventions on board per protocol or maybe per doctor's orders, hopefully as a team, getting these things done really quickly because we want to get that Epi on board in less than 5 minutes, which it's hard to imagine getting through all of this in less than 5 minutes. But really that's what sort of gives us best outcomes for our patients. Okay, I'm going to take a deep breath. Any questions? Write in the show notes. I'm going to move on from that care to realizing once we've stabilized the patient, we've given Epi, we've been able to manage those symptoms, we're checking vital signs every 5 minutes. And we're going to want to monitor the patient from 4 to 6 hours and potentially longer depending on provider care, essentially decisions or guidance. But what we're going to want to do for this patient, but also any patient that comes in with a diagnosis, new diagnosis of allergies, is really give them quality education. Because what we're seeing in the data is that most patients aren't actually carrying their EpiPens on a regular basis. Some of them just have one EpiPen. Unless they've had an episode of anaphylaxis, they don't really take it seriously. So a lot of people are vulnerable, and people in the studies that I've looked at show that over 60% of patients surveyed said that really good provider education made a big difference in their compliance. So we want to do a really good job of essentially getting good education to them. So what does good education look like? First is what we'll call an allergy action plan. And we can download these from, I believe, UpToDate, maybe Medscape, but specifically we can get it from the American Academy or American College of Allergy, Asthma, and Immunology. They have templates for action plans for showing our patients how to manage. And it's going to be like a checklist of how and when to use your EpiPen. But the better part of anaphylaxis is avoiding it. And this is where good education can really help. What does it look like to really try to avoid some of these things? We can talk to our patients with food allergies about how to read labels. Personally, I would say this is a great opportunity for patients to improve their diets, because the best way to be able to avoid these is to not eat prepackaged foods. If you're cooking your foods from scratch, if you're buying lots of vegetables and fruits, you know exactly what's in the food that you're eating, and you can learn how to do this in a really satisfying and effective and cost-effective way by managing your vulnerability to some of these things by actually controlling the things that come into your house. Patients will, or families will, make a choice whether they just exclude allergens outright from their house or they store very, very safely specific allergens. People do it various different ways. We can use medic alert jewelry to be able to alert first responders of a history of allergies, severe allergies. That can be really helpful if you became so hypotensive or in respiratory arrest that you weren't able to communicate. Or maybe you have three-word dyspnea and you're just not able to say the words in a complete sentence and require that much oxygen. Environmentally, we can give education on how to avoid some of these things. Air filters and sort of lifestyle decisions about when you go out, where you go out, where you live, where you don't. Mold isn't even on here, but certain parts of the world are going to be very hard to manage mold, and so some people have certainly relocated nationally to manage their access or their vulnerability to these types of allergens. Toxins, snakes, we don't have many of these. These are mostly in the desert, and the really dangerous jellyfish are commonly around Australia, and sometimes off of our coast. Box jellyfish have the highest rate of severe anaphylaxis. And so these are less of the problem, but medications, we're going to really want to sort of talk to our provider and make sure that it's well charted where we go to the hospital. We want to be a self-patient advocate so that we are making sure that our providers always know this and that anyone who's coming and administering medications is aware of it. So taking some self-control. When we look at vaccines, we might have some issues with eggs, and even a little bit of dried lactose can happen from time to time. Shellfish is generally specific to itself. You don't find that, and sometimes we have some anticoagulants that are made out of shellfish shells, and those do not elicit a response, nor do smelling things that you're allergic to generate a response. It's a different molecule. However, cooking things, when they're being vaporized in steam from cooking shellfish, for instance, is the same molecule. That is parts of the allergen being essentially aerosolized, but more just put up into the air, being carried on vapor. And that has certainly caused allergic reactions. So there's a little bit of variability, and we need to be able to answer some of these questions, because to be able to do so and provide really quality education is going to be a big portion of keeping our patients safe. Cost is a major factor in whether people are able to carry epinephrine. The cost of EpiPens has fluctuated from as low as $99, I think, 20 years ago, when the company who originally came out with EpiPen was bought out, and they were bought out by a competitor, and the price was raised to $700 for an EpiPen. You can imagine how that's untenable for most low socioeconomic class individuals. There are rebates that are available that can get that cost down sometimes to $400 or $500. I've seen the cheapest I've seen online was in the sub $300 range, and most I saw was an AVQ for $5,000. Is that right? It's hard to imagine. Just checking my notes there. $5,000 AVQ, which is incredible. So there is an easier way, cheaper way, harder way, not easier, and that's to use IM Epi. So you can buy vials of Epi for $5, which is much like what EMS is now doing and emergency rooms. But you need training on how to do an IM injection. But you can, if you are willing to go that route, I have an example here. Okay, here is what sort of an Epi Administration Kit might look like. Just a small sharp shuttle with some vials of Epi, some IM injection needles, and syringes, and some alcohol swabs and a Band-Aid. So this ran very long, so I'm going to stop here. Thank you for maybe watching, but I will say that it was a lot for my education. I learned a lot by doing it. Thanks for allowing me to do a really interesting project, and have a great day. Thank you.